Welcome, everyone. My name is Dr. Bruce Strumminger. I'm with the University of New Mexico Project ECHO, and it's my pleasure to welcome you to this month's session for the Advanced HIV Disease Global ECHO webinar series. Today's topic is on non-tuberculous bacterial infections in advanced HIV disease, and we'll be having an exciting debate about approaches to that. Just going to run over a few logistics slides. First one being that we are offering French interpretation today. And for those who would like to take advantage of that, please go to the little globe icon down in the bottom right on the Zoom toolbar and click if you'd like to hear French interpretation, or click back to English if you need that. If you have any IT issues, please mention those in the chat and we'll try to address those as best we can. We're really looking forward to your questions and comments today. Please put those in the Q&A feature down along the bottom of the Zoom toolbar. Also, if you can mention which speaker you'd like to direct your question to, that would be great. That'll help us in answering the questions. Just to let everyone know, the presentation slides for today and a recording of the session will be shared on the ECHO website for this series, and we'll also share it through follow-up emails to everyone who registered after the session. We'll share a link to that website in the chat for those who want to go there, and we also have an archive of all the recordings of the sessions for nearly the past year for this series. We are recording this session, as I mentioned, as we always do, and your attendance is consent to be recorded. We're also offering certificates of continuing medical education and attendance through the University of New Mexico, where Project ECHO is based. We'll share a link to the survey in the chat about 15 minutes before the end of the session. That link is open for 48 hours. We really appreciate your feedback. It's how we do continuous quality improvement and plan for future sessions. So please take advantage of that opportunity. Also, we really want to encourage everyone to scan the QR code that's up on the screen here. We'll also put a link in the chat so that we can register attendance. This will help us to ensure that your CME credits and certificates of attendance are processed properly. It'll just take 10 seconds to put in your email address, etc. So we appreciate that to help us know who's participating and where in the world you're based. Last note on data use, we just want to ensure and remind everyone we take data stewardship very seriously, and we'll be keeping your individual data confidential. We may be sharing aggregated, de-identified data with our partners to create maps and other things to inform and share results about participation. So with that, just putting up the agenda for today's session, and I'm going to pass it over to Dr. Tom Chiller with the Mycology Division at CDC. Tom? And then I'll bring
Thanks, Bruce.
Down.
Thanks, Bruce, and welcome everybody. Great to be back for another session in our Advanced HIV Disease series. Just gonna make a couple introductory remarks with a couple slides. Bruce, there you go, thank you. We'll share my screen here. All right, so as I mentioned, great to be back with all of you for another session in our series on advanced HIV disease. We're sort of excited this time, even more so than usual, because we're addressing a topic that I think is really under addressed, and we're excited also to have our first live debate about the pros and cons of using antibacterials. So I just wanted to mention that, obviously we're still in this pandemic. We're seeing some good signs and some bad signs depending on mutations in virus. And we just continue to need to remain focused on the fact that during COVID-19, we are still seeing all the other suspects that have been causing pandemics and epidemics for years. HIV obviously is included in that. I think we've been talking in this series about advanced disease now for a while. So those of you who've joined are well aware there are factors that are contributing to the presence of advanced HIV disease around the world, and unfortunately continues to be a major problem. And when we look at some of the causes of death, we know TB, crypto, and severe bacterial infections are all playing major roles. So we're going to address the severe bacterial infections. So what's the deal with these? Why are we troubled by them when they tend to be so common, not only in HIV, but in non-HIV populations? Well, they're often missed in the HIV populations and diagnosed late, so better diagnostics are needed. They're often not classified as OIs, and so maybe we're not emphasizing enough on reporting them. As with many of our infectious diseases, they can be mistaken for other things, especially for things like TB. And then, of course, there's this resistant issue that we talk about a lot, and that can cause us to not be able to treat them, and we are in a need for better treatments. So partly how we can address this is access to diagnostics. We need to improve lab capacity, develop new and expensive point of care tests for these bacterial infections. We need to continue our better understanding and epidemiology of resistance, where it occurs, how it's occurring. We need to think about the role of antibiotic prophylaxis when there's a proven mortality benefit, and we'll talk about that today. And then finally, talk about vaccine development. There are already some prophylactic strategies out there for antibacterials. We know about TB preventive therapy, IPT, something that is recommended for persons living with HIV who do not have active TB. We know about co-trim prophylaxis that prevents some, but certainly not all bacterial infections. And the guidelines are pretty clear that prophylaxis to everyone living with HIV, regardless of CD4 count. However, despite both of these being around for a little while, they're still underutilized or underused. And so we need to continue to talk about this subject with our colleagues in the HIV treatment work. So I just wanted to give that very brief introduction and then move on to the rest of our program. Let me just introduce the first three speakers, and then we'll introduce the debate speakers after that. We're excited to have a great panel of speakers today. We're going to start with Dr. Elfriede Agyeman. She is a medical officer with the HIV Care and Treatment Branch of the Division of Global HIV and TB at the Centers for Disease Control and Prevention, where I am located. And she's also the co-lead of the Advanced Diseases Unit, followed by Rashida Farrand. Rashida is an epidemiologist and an HIV clinical specialist. She's a professor at the London School of Hygiene and Trop Med and has been based in Zimbabwe, hosted by the Biomedical Research and Training Institute in Harare for the past 20 years. And finally, Di Gibb. Diana is a pediatrician and professor of epi and clinical trials at the MRC Clinical Trials Unit at University College London. Over the past 30 years, Di has set up and coordinated a network of clinical trials and cohorts across Europe, Thailand, South America, mainly with pediatric HIV infections. So without further ado, we'll turn it over to Dr. Elfriede.
Thank you, Dr. Chiller. Good morning, good afternoon, and good evening. I'll be giving an overview on non-tuberculous bacterial infections and advanced HIV disease. Next slide. So global scale-up of ART has been very successful in reducing mortality. However, there's been persistent and large burden of HIV-associated morbidity and mortality in countries most affected by HIV. Although the number of people living with HIV on ART, as shown in the gray line, has increased greatly, we've seen a decline in mortality, which is shown in the black dashed line. And that has been slower. That decline has been slower. This means that there's a large proportion of patients still at risk of death. This image, however, does not fully capture the impact of test and treat, which was implemented starting in about 2015, 2016. Next slide. In a meta-analysis that looked at in-hospital mortality amongst adults and children living with HIV worldwide, which was conducted in 2015, Ford et al. Found that in-hospital mortality was 20% overall in adults and 14% in children. Highest mortality occurred in Africa. The most common causes of mortality in adults and children were AIDS-related infections, as well as bacterial infections. In adults, tuberculosis was the leading cause of death with a mortality of 27%, shown in the top red box, followed by bacterial infections, which had a mortality of 23%, shown in the second red box. In children, bacterial infections was the leading cause of death with 36% mortality, followed by TB and pneumocystic pneumonia. Next slide. The same meta-analysis also showed that AIDS-related illness and bacterial infections were the most common causes of hospital admission among adults. Next slide. And also in children. Similar trend was seen in all geographic regions with bacterial infections and AIDS-related causes being major drivers of hospital admissions. Next slide. So now let's narrow down on severe bacterial infections and advanced HIV disease. HIV-related mortality and morbidity are more pronounced among people with advanced HIV disease or AHD due to a high degree of immunosuppression. Severe bacterial infections or SBIs, such as pneumonia, empyema, bacteremia, and meningitis are characterized by fever accompanied by specific symptoms and signs that localize infection and isolation of bacteria from appropriate clinical specimens, usually from sites that are sterile. Unlike TB, severe bacterial infections often receive less attention, but are also increasingly common and more severe as the CD4 counts decline. And this is a result of many reasons, as Dr. Chila mentioned earlier on. Some bacterial infections are not AIDS-defining illnesses, so people miss that. We also have laboratory and diagnostic resources to confirm diagnosis, which are scarce. And then also severe bacterial infection morbidity outcomes are not well documented or recorded in HIV clinical trials. Next slide. Severe bacterial infections can present in several clinical syndromes and include bloodstream infection, which is a common cause of hospitalization. Common risk factors for bloodstream infections include low CD4 count, with a 7-fold increased risk for those with CD4 count less than 200. Also, high viral load, untreated HIV infection, and treatment failure are all risk factors for bloodstream infections. Other clinical syndromes include respiratory infection, which occur regardless of CD4 count. Risk factors for respiratory infection increases as CD4 counts decline, and is greatest when CD4 count falls below 200. Other risk factors for respiratory infection include smoking, prior pneumonia, alcoholism, and other comorbidities. Bacterial meningitis, enteric infections, endocarditis, skin and soft tissue infections, joint and bone infections, and urinary tract infections are all clinical syndromes of severe bacterial infections. Next slide. Invasive non-typhoidal Salmonella disease and Streptococcus pneumoniae are the predominant causes of severe bacterial infections in adults living with HIV globally. This is followed by E. coli and Staph aureus. In African countries, strep pneumoniae most commonly cause bloodstream infections in children. And non-typhoidal salmonella is the most common cause of bloodstream infections in adults. Also, Treponema pallidum, which causes syphilis, is another major contributor or cause of severe bacterial infection. Other pathogens like Nocardia and Rhodococcus cause bacterial infections. And they're actually very complicated because they can mimic TB, both in clinical presentations, because they can present as cavitary pneumonia, and also in diagnostics. They are weakly acid fast, and so can sort of confuse with diagnosis of severe that infection with those species. Next slide. So over recent years, severe bacterial infection incidence and mortality have declined with ART rollout and implementation of test and start or treat. Immune reconstitution with ART is thought to be critical to reducing the burden of severe bacterial infections. In the START trial, in which over 4,600 ART naive persons living with HIV with CD4 count, more than 500 were randomized to either immediate ART or deferred ART until their CD4 count fell below 350. PLHIV randomized to immediate ART had higher CD4 count compared to those that were randomized to the deferred ART group. And this reduced severe bacterial infection, which included an endpoint combining both TB and other severe bacterial infections by 61%. And when they looked at severe bacterial infections without TB, their risk was reduced by 59%. So this shows that immediate ART reduced the risk of severe bacterial infections among PLHIV with high CD4 counts, which is partly explained by ART-induced increases in CD4 count. Next slide. So is early ART alone sufficient in reducing severe bacterial infection incidence and mortality? Results from the reality trial, an open label randomized trial conducted in 4 African countries, helped inform WHO guidance addressing this question. About 1,800 participants were randomized to either enhanced prophylaxis, OI prophylaxis arm, or standard prophylaxis arm. Those in the standard prophylaxis arm received ART. At the time, it was NNRTI and 2 NRTIs, as well as cotrimoxazole. And those in the enhanced OI prophylaxis arm received ART, and in addition to that, they also received azithromycin, albendazole, fluconazole, and a fixed dose combination of INH, vitamin B6, and cotrimoxazole. Next slide. So these graphs here show a little bit about the death rate amongst the participants, as well as at the bottom graph showing the rate of both fatal and non-fatal events. So on the top row, you can see the darker line is very hard to tell, but the darker line show those who were on enhanced prophylaxis, and then the grayish line show those who were on standard OI prophylaxis. The graphs here show that enhanced prophylaxis did not reduce deaths from tuberculosis, severe bacterial infections, or even potentially azithromycin responsive infections. On the bottom row, it showed that enhanced prophylaxis reduced non-fatal or fatal tuberculosis, but not severe bacterial infections or other potentially azithromycin responsive infections. Next slide. So there are a few takeaway points, and we may hear a little bit more in the presentations to come. But first, severe bacterial infections are recognized as a common cause of morbidity and mortality among PLHIV, especially in resource-limited settings. Thus, the WHO recommends cotrimoxazole use irrespective of CD4 counts in settings with high burden of bacterial diseases. PEPFAR also supports this recommendation, and actually in their COP21 guidance has mandated that no PLHIV in PEPFAR programs pay for cotrimoxazole. Immediate initiation of ART also reduces the risk of tuberculosis and non-tuberculous bacterial infections. However, due to unclear benefits of additional azithromycin in reducing severe bacterial infection morbidity and mortality in the Reality trial, and the concern for increased antimicrobial resistance, the WHO guideline development group did not recommend additional broad-spectrum antibiotics to the advanced HIV disease recommended package of care. And we'll hear more later on today. And then lastly, further research assessing the role of broad-spectrum antibiotics in reducing severe bacterial infection incidence and mortality among PLHIV, especially among those with advanced HIV disease, is urgently needed. Thank you very much.
Thanks very much for a nice, concise presentation on challenging issues with advanced disease. Let's turn it over to our second speaker, Rashida. Thank you.
Hello, can you hear me?
Yes, go ahead.
Okay, so I'm going to talk about the BREATHE trial, which looked at azithromycin for management of HIV-associated chronic lung disease in African children. So I'm just trying to move my slide. So by way of background, HIV-associated chronic lung disease in children in Africa is common despite antiretroviral therapy. And several studies across Africa have shown that it's associated with poor lung function and substantial morbidity. Chronic lung disease in the ART era affects small airways and may be a consequence of repeated respiratory tract infections and or chronic immune activation. And it's a different profile from the chronic lung disease we used to see in the ART era, which was largely interstitial disease, commonly known as lymphoid interstitial pneumonitis. So the hypothesis of the BREATHE trial was the use of azithromycin would improve both lung function and morbidity through preventing respiratory tract infections and controlling systemic inflammation. Indeed, azithromycin has been used in other chronic lung diseases in both children and in adults, and has been shown to reduce the risk of acute exacerbations in chronic lung disease, such as cystic fibrosis and chronic obstructive airways disease. So this was an individually randomized, placebo-controlled, double-masked trial conducted in Malawi and Zimbabwe. The definition of chronic lung disease in this study was using a spirometric measure of forced expiratory volume in 1 second, or FEV1, with no reversibility, to exclude those who might be on the asthmatic spectrum. And it includes children with HIV who were on therapy for at least 6 months and were aged 6 to 19 years. Children were randomized to once weekly azithromycin that was weight-based or placebo for 48 weeks. And the primary outcome was FEV1 score at 48 weeks. And importantly, a clinical outcome that was included as a secondary outcome was acute respiratory exacerbations, which included either worsening of respiratory symptoms or respiratory tract infection. Other outcomes were mortality, hospitalizations, and other infections, which I will come on to shortly. The continuous outcomes were analyzed by linear regression, and we used robust standard errors to allow for heteroscedasticity, which is essentially differing variance by age group. And we adjusted for site and baseline FEV1 score, and we adjusted for variables associated with missingness at primary endpoint. Time to event data was analyzed using Cox regression, and we adjusted for all variables that were slightly imbalanced at baseline, which included age, sex, and viral load, as you will see shortly. So there were around 1,500 individuals assessed for eligibility, and the majority of them were excluded because their FEV1 score was outside the eligible range, or they were not able to perform spirometry. We included 347 participants, and the primary outcome was measured in 83.9% in the placebo arm and 93.6% in the azithromycin arm. And the reasons for withdrawal, loss to follow-up, or other reasons for non-assessment are given on the flow chart. So we had pretty good follow-up at 48 weeks. So you can see that the azithromycin arm participants were diagnosed with HIV slightly younger. They started ART slightly younger, and they had a slightly lower, smaller, shorter duration of ART. With slightly a higher rate of virological suppression in the azithromycin arm, but not a very big difference. But these variables were adjusted for. So in terms of the primary outcome, which was the FEV1 score measured at 48 weeks, there was no difference by the trial arms, and even stratified by sex, there was no difference in trial arm. However, when we look at the clinical outcomes, there was a significant difference in the risk of acute respiratory exacerbations when you consider the risk to first acute respiratory exacerbation and all acute respiratory exacerbation, with a much reduced hazard ratio of 0.52 and 0.51 respectively. And there was a reduced risk of all hospitalizations. The p-value did not make it to the magic 0.05, but as you can see that there is a pretty remarkable difference with a hazard ratio of 0.24 in reduction in the risk of hospitalization in the individuals who took azithromycin. Then if we look at the intervention on effect of the intervention, other outcomes, these were not formally analyzed because they were rare outcomes, but I'm just presenting the rates. The rates of death, malaria, and gastroenteritis were lower in the azithromycin arm, but we clearly can't make any statistical comparisons as they were such rare events. And the Salmonella typhi and non-typhi infections, there were 0 infections in either arm. Importantly, azithromycin was very well tolerated with really no DAIDs, grade 3 events. There were grades 1 or 2 events, which were largely gastrointestinal and self-limiting. And importantly, we measured adherence. We defined adherence as missing missing more than 3 doses on average, and good adherence was missing less than 3 doses on average across the 4 quarters of the year. And the adherence was actually better in the azithromycin arm compared to the placebo arm. And the non-drug related side events, which were DAIDs graded, were actually higher in the placebo arm than in the azithromycin arm. We had a nested case control study comparing chronic lung disease with a control group that was which did not have chronic lung disease, defined as a FEV1 score greater than 0, no respiratory symptoms, or known chronic lung or heart disease. And controls were matched for frequency matched for site, age, and ART duration. What you can interestingly see is that the bacterial isolates on nasopharyngeal swab, that the prevalence of colonization of strep pneumoniae was significantly higher in the CLD positive group compared to the CLD negative group, and the same applies for Moraxella catarrhalis. Both infections are responsible for respiratory tract infections, and the CLD positive group had a higher prevalence of being colonized by more than one bacterial species. And the strep pneumoniae non-susceptibility to penicillin was higher in the chronic lung disease group compared to the non-chronic lung disease group, which may imply kind of having received multiple antibiotics previously. These findings are currently under review. So the other aspect that we looked at is the markers of immune activation, work done by Dan Hameri Bowen at the University of Oxford. And one paper that is in press has shown that the levels of E-selectin and MMP, which are both the E-selectin being involved in recruitment of neutrophils to an inflammatory site, and MMP involved in tissue repair, were much higher in individuals with chronic lung disease compared to people who did not have chronic lung disease. And again, this is ongoing work, but Dan kindly has shared the slides and showed that in the azithromycin arm, the levels were much lower for all three of these biomarkers at the end of 48 weeks. So there appears to be an impact on immune activation, both in terms of CRP, which is a global marker of inflammation, as well as biomarkers involved with tissue repair and chronic inflammation. So in conclusion, this is the first trial ever of an intervention to address HIV chronic lung disease in children in the ART era. We didn't see an effect on FEV1 Z-score, but participants had lower incidence of acute respiratory tract infections and hospitalizations. It's safe and an effective intervention in reducing morbidity. The investigation of impact of azithromycin on indeed at 80 trial team partners who took part in this project. Thank you very much.
Excellent. Thank you, Rashida. And I apologize for mixing up the order, just trying to keep you all on your toes today. It's my word speaker, Di Gibb. Di, over to you.
Hello, everyone. Can you hear me?
Yes, we can.
Great. Okay. So thank you very much for inviting me to present the reality trial, which just make sure this is working from the beginning. There we go. Right. Which was the PI for. So this was looking at, and you've already heard a bit about it, so I can go a bit quicker, looking at reduce early mortality. So by way of background, when this trial started, we actually had a not such a good idea about what percentage of patients might be presenting late, but various studies have shown that quite a high percentage of patients are presenting still with very low CD4 counts. They have high early mortality rates. And really, in our discussions when we were setting up this trial in 2013 was what could be causing this? Could it be high rates of infection or just advanced HIV disease with lots of high viral load, or possibly could malnutrition be contributing? And some of the data from here is from the DART trial showing this early peak of mortality, which is highest in those who've got low CD4 counts, below 50 in red and from 50 to 100 in orange. So that's adults. And we also saw the same thing in the ARROW trial, which is children, this high mortality just after starting ART. So the questions could be, Is it related to infections? Should we be giving prophylaxis or preemptive treatment? What about giving more intensive ART, and what about giving extra food? So I'm not going to go into the other two randomizations, but we did a 2x2x2 factorial trial to look at these questions. And here in red, I'm going to focus on the anti-infection questions. In fact, this was the only randomization that really yielded positive results in terms of mortality. So going into that in a bit more detail, we had adults and children over 5 years with CD4s under 100 in this trial. And at the time of starting antiretroviral therapy, they were randomized to enhanced prophylaxis, which was cotrimoxazole plus INHB6, and I'll say a bit more about that in a minute, 12 weeks of fluconazole at a lower dose than's been used before, 100 milligrams per day, 5 days of azithromycin, a single dose of albendazole. So you heard that a bit earlier. And the standard of care was cotrimoxazole. And for most countries, we gave the INH at 3 months. So that was added into the control arm. We used a fixed dose combination tablet newly developed, which is now in the essential drug list. Adults got a single pill a day and children got half a pill. So this is where the trial took place. It finished in 2016, 8 clinical centers in Uganda, Zimbabwe, Kenya, and Malawi. I can say that it enrolled faster than we expected, particularly as results were coming out to suggest test and treat should happen. And we even thought we might not be able to enroll because there wouldn't be any advanced disease, but we enrolled very fast. And of note, the assessments at baseline followed guidelines, WHO guidelines, but we didn't mandate that they had to have lab diagnoses. These were clinical assessments really for identifying those that might need any treatment, for example. I'll come to that in a minute. So just something about the baseline characteristics. We actually, despite a lot of looking, didn't manage to find many children. There were under 100 children. CD4 counts, though, were extremely low. So the median was only 37 cells, and a third had CD4s under 25. But despite that, about half only had stage 1 or and many had. Might ask you, what effect do you think enhanced prophylaxis would have on the primary endpoint, which is was mortality at 24 weeks? So the question is whether it does harm, because people were very worried about side effects of giving additional drugs at the time of starting ART. It has no effect. It reduces mortality, but less than 20%, 20 to 40%, and more than 40%. This is partly testing whether you read the paper. Okay, please do the poll. I'm not seeing a poll coming up. Are people still hearing me?
Yes, there it is, Di, I think.
Okay, great. So you've got 30 seconds to fill in that poll. Please, everyone, all 168 of you in the audience who I can't see. Okay, can we show the results of the poll? There you go. Well, that's an interesting, quite a wide spectrum. So a few people thought, 3% thought it would do harm, 10% no effect, 31%, so we're getting up nearer half of you, thought it had a benefit of less than 20%, 35%, 20 to 40%, and 21% more than 40%. Okay, so we go on to show you the results. And can you let me continue? Oh, I have to close this, or just, what do I have to do? Close it? I'm going to close it. Because my slides seem to have got frozen at a very tantalizing moment.
Hi, Di, go ahead and close it and then click on your.
I've closed it
Okay.
already. So I'm just, maybe it's just takes a while to wake up. There we go. So here are the results. So at 24 weeks, mortality in standard prophylaxis was 12.2% versus nearly 9% in enhanced prophylaxis. That's a reduction of 27%. So about a third of you got that right. And that was sustained out to 48 weeks. Just a couple of notes in here. Loss to follow-up was very low. We actually saw no benefit on mortality of the other two randomizations, and there were no interactions either. So here's a summary of what we saw. Putting it another way around, if you treated 100, or you gave 100 individuals that enhanced prophylaxis package, you would save just over 3 lives. And it also reduced TB incidence, but not mortality, as has already been mentioned. It reduced cryptococcal disease, both incidence and mortality, reduced candidiasis. There was no change in severe bacterial infections with the intervention, but as already pointed out, very hard to diagnose, and most places were not doing cultures. And it also reduced hospitalizations by 17%. So the next question really was really about how it worked. This is the paper, which was published in July 2017. I've put on here, and you can come back and look at it. There's a nice little video which was filmed in Malawi of about 7 minutes, which shows you the results very nicely. So what are the causes of the deaths, and when did they occur? Well, this shows the reduction in cryptococcal disease and also unknown deaths. And you can see that the other causes, the differences were not significant. And this is from the appendix of that New England Journal, and already referred to a little bit. Most of the deaths occurred in the first 24 weeks. You've only 188 versus only 37 deaths after 24 weeks. And most of them were cause unknown. So 7.5% due to cryptococcus, 40% cause unknown, and mostly extremely early. So this is overall mortality rate, which peaked at day 18. So that's only 2.5 weeks after starting ART and the prophylaxis. And a lot of patients hadn't even come back to clinic. They went home and they died very soon afterwards. And then if you looked at the cause specific, you've got a similar sort of picture, and the one on top is the unknown deaths. This is from cryptococcal disease here, showing there was a significant benefit and could be attributed to the fluconazole prophylaxis. And this is the unknown cause, excess deaths, also significant. And one of the things that happened with the WHO guideline group was that a lot of people said, well, that's likely to be due to cryptococcus probably, and you didn't do CRAGs at baseline. So one of the things is, could it be cryptococcal disease, or is it undiagnosed bacterial infections? And how do we find out? Well, we went back and did CRAGs on all the baseline samples. And this was presented at CROI and is actually, unfortunately, got a bit stuck in the process of being, it should have been published earlier this year, but got a bit stuck this year in the process. But what it shows is that, you know, in the CRAG cryptococcal deaths here, you saw a benefit in those that were CRAG positive. You saw that with the new cryptococcal disease as well, but you didn't see anything in the deaths of unknown origin. So what we were saying here is that nearly all the deaths in the unknown cause were CRAG negative, suggesting they're unlikely to be, very unlikely to be cryptococcal, and indirectly supports the efficacy of azithromycin in preventing those deaths. We've also got a basic science grant ongoing, led by Professor Andy Prendergast, asking questions, looking at molecular techniques to look at whether enhanced prophylaxis reduces bacterial infections, also looking at inflammation, as already mentioned by the previous two speakers. We've got looking at both systemic and gut inflammation, and at about 20 different biomarkers. And we'll also be looking at whether biomarkers reduce mortality. Now, all the data nearly is done, nearly all the analyses have been done, but I haven't got results for you just yet. And then we've done cost effectiveness analysis within the trial. In that Reality main trial, there was a within trial analysis showing that cost per QALY fell within the cost effectiveness thresholds for African countries. And they followed it up with doing a longer term economic analysis and also comparing it with other strategies, for example, doing testing, for example, CRAG testing. And I think one of the difficulties with doing diagnostic testing is that things happen very quickly, and we know we should get patients like this onto ART quickly. If you're going to add in prophylaxis, the question is, you know, is it going to be non-beneficial to wait for results? So if you are going to do tests, we do need them to be point of care. And the additional work they did was to show that it was cost effective for patients with CD4s under 200 using modeling techniques. So another poll for you, which is based on the data from the Reality trial. Would you want to give cotrimoxazole and isoniazid, and you could add to this now because the guidelines have changed, TB prophylaxis at ART start? Would you like to add in fluconazole? Would you like to give the enhanced prophylaxis bundle, which we do reiterate is a bundle, and it's difficult to pull the different bits apart? So vote away. Okay, you only had to look at 3 things. So are we nearly there, do you think, with the results? So 62% of you said you'd give the whole bundle. 25% would add fluconazole to what is being given currently, cotrimoxazole and isoniazid, and 13% would just give the 2. So that's very interesting, and is rather different, I think, to what was being said at the guidelines meeting in 2017, where there was quite a few concerns. So as soon as I'm able to, I'll go to the next slide, and I've nearly done then. I think, unfortunately, doing polls in the middle of your talk means your talk gets slowed down. Apologies.
You can close that window if it's open and move ahead.
I've closed the window a while ago. So sorry about that. I may have to just tell you what's on the next slide, which is basically a summary. Maybe it'll come now. No, it doesn't want to. A summary to say that there's three things really. One is the results that I've already shown to you about the reduction in mortality, the fact that we didn't see side effects. The second is that clearly, because of the numbers of people who are asymptomatic at baseline, you have a problem if you do not know the CD4 count. So really, to benefit from this intervention and to know people are at risk of high mortality in the next 3 months, that 10% we talked about, you really do need to know what their CD4 count is. And the third point I was going to make was that a lot of these patients, we did some social science, presented late, but didn't realize they should be presenting earlier. And I think the public health messages about early presentation and can do something about your disease are very important here. And if you look at that little film, it shows, which you can see later on, it shows what can be done there. And the WHO guidelines in 2017 in advanced disease, they didn't take reality completely as it was. We talked a lot about the fact that the bundle was all together, if you like, but azithromycin was not recommended, mainly because of concerns about possible resistance. Although I think since then there have been more studies of azithromycin prophylaxis in other populations, and in fact earlier this year another publication looking at it in less high risk patients actually. So I think it looks to me like people are moving more towards accepting that that this may be a valuable addition to this bundle. So I'm sorry that my computer has completely frozen on this one, and I blame the polls. Thank you very much.
Thank you very much, Di, and all of the speakers for those excellent presentations where we've been challenged to think about some different strategies for antibiotic use in advanced disease, and also we've heard some of the counter argument. So this is a topic that not everyone agrees on, and we are going to have a debate. And as Tom said, this is the first time we're having a debate as part of this webinar series. And the question that our final two speakers will be debating is, we should routinely use additional prophylactic antibiotics in people with advanced HIV disease. And before I introduce our two speakers, we are going to have a poll to ask everyone in the audience what is your view on that question. So if Echo Team, if you could put the poll up now, please. Please, if everyone could try to give their opinion on the poll, it will just make the poll after the debate that much more meaningful. And we will see if you have been swayed by the arguments of the speakers. Just another 10 seconds or so to complete that poll. This is, as Di was saying, this is an area of discussion, and we are not proposing that you go out and do something that is not within your national guidelines, but we are debating here a question of perhaps how things could or could not change in the future. So I think we will stop the poll there, and if we could please have the results. Okay, so that is interesting. We have about 2/3 of people agree with the statement we should routinely use additional prophylactic antibiotics for people with advanced disease, and about 1/3 disagrees. So it will be interesting to see if and by how much that changes after you hear the arguments that will be put forward in favor by Professor Sam Fury and against by Professor Mark Mendelsohn. Sam Fury is the Programs Director for Partners in Hope, providing support to a lot of different programs. Before that, he was the Executive Director of the Lighthouse Foundation in Malawi, where he was involved with a huge amount of innovative and important work on advanced disease. Mark is Professor of Infectious Diseases at Prudential Shore Hospital in Cape Town, and he is an expert on antimicrobial resistance and chair of the Ministerial Advisory Committee on Antimicrobial Resistance. So two people excellently placed to debate their respective positions. So Sam, over to you, please. Oh, sorry, just one other thing to add. The format for the debate, each speaker will have 7 minutes, followed by which we will open this up to the audience, and we will end with a quick summing up by each speaker. If you would like to ask questions, please indicate on the chat so that you would like to speak, and we will try and patch you through directly. If you would not like to speak, that's fine. We can relay your questions to the speakers. So Sam, please go ahead.
So thanks for that introduction, and also I'd like to thank the organizers for actually asking me to participate into this debate. It is exciting that we are going to be doing the first debate, and we'll be working on the basis of on the pro in this case. And these are my disclosures, which are available now. And in this case, the question is, should we actually, in this case, should we be able to routinely use additional prophylactic antibiotics in people with advanced HIV disease? And in this case, I will be doing 4, and I will be actually taking through the team towards that. It's clear that people with advanced HIV disease frequently have severe bacterial infections. We've seen this already in the presentations that bacterial infections are estimated to cause more than 1/3 of hospitalizations. And it is also clear that we've seen that advanced HIV disease burden of mortality and morbidity from severe bacterial infections is actually poorly studied, especially in Africa, because of the challenges with the diagnostic facility, which are lacking. And the lack is also, unfortunately, not only through the studies, but also the diagnostic information in the very routine use, which is actually difficult. What we've seen so far from the presentations that contimoxazole or prophylaxis protects against some more severe bacterial infections. And actually, we know that WHO recommends the lifelong contimoxazole prophylaxis for people living with HIV, regardless of CD4 cell counts, and especially in the settings where malaria and is high prevalence, including the bacterial infections. So one other component which so far is that the immediate ART initiation reduces the risk of severe bacterial infections. So we see that the area we need to understand that the reduction of bacterial infection may also account for some of the survival benefit that we've seen in the early stage. Now, coming up to supporting the proposal to actually use the antimicrobials in just to look at use of azithromycin in the model study, which was actually in this case, this was seen as a general component rather than within the HIV advanced disease. But this actual study, which was done in Tanzania, Nigeria, and Malawi, and found that bacterial prophylaxis with azithromycin was to reduce mortality in children. This actually was quite significant in Nigeria for the presentation over that. So what we're trying to do is just to emphasize the role of antibiotics, in this case in the advanced HIV disease. As we've seen, this one was amongst children, but we can be able to extrapolate that as we talk later on. Now, the secondary analysis for the Mordor Trial, which was looking at the effect of mass treatment with azithromycin on causes of death in children in Malawi, this actually was able to look at respiratory and gastrointestinal infections, including a background HIV exposure or infection, for example, in Malawi. This actually led to a reduction in the rate of pneumonia and diarrhea as immediate causes of death. So we think that this is certainly plausible that we can consider as we talk about this. So now, Dai has already gone through this. Let us simply look at reality. What was done? Patients received a bundle of prophylaxis beyond CPT. This was fluconazole, tuberculosis preventive therapy, INH, vitamin B6, and also albendazole and azithromycin for 5 days. What we've seen is that the significant survival benefit from enhanced bundle of antimicrobial prophylaxis was seen, as already talked about, Dai. The rate of death with enhanced prophylaxis was lower than that with the standard prophylaxis. So let's just try to dissect of that. We saw that there was the enhanced prophylaxis reduced actually death in this case in components of cryptococcal meningitis and also unknown as represented by Dai, but not tuberculosis and also the severe bacterial infections, and also those with potential to respond to azithromycin or other causes. So one thing which I wanted to emphasize is like lack of impact on bacterial infections raised some questions about using 5 days of azithromycin with the enhanced prophylaxis. But a third of all deaths from unknown causes occurred within the first 4 weeks after ART initiation, and many occurred at home, making it to say that azithromycin had no role in reducing and diagnosing severe bacterial infections causing these early deaths. So what I wanted you to understand is that lack of evidence for effect should not be confused with evidence for lack of effect. Now, when we move to, let us look at the reality. If you order a bundle, you expect to get a bundle. If the order is changed, you may be in for a disappointment. So causes of death were multifactorial because these were very sick patients. So most had several secondary causes adding to mortality, and many patients died at home and had unclear cause of death. That is why we do not really know what part of bundle prevented the death. So development of antimicrobial resistance is a risk. We understand that. We acknowledge the risk of resistance development and its general increase globally, but no studies have shown this to happen in individuals receiving 3 to 5 days of azithromycin. So in the real world, azithromycin is frequently dished out as part of Helicobacter treatment in patients with questionable gastric ulcers, for upper respiratory tract infection in patients who may also well have viral causes, and lately for almost anybody with COVID infection, whether symptomatic or not. Let us try to get it right first because of the short-term use in selected patient population and advanced HIV disease. We have at least some data, and these patients are very vulnerable at a high-risk death. So the reality package and azithromycin, we know that this may modulate the inflammatory milieu through reductions in subclinical infections. So I think in this case, we look at enteropathy, we look at microbial translocation, also through direct immunomodulation effects. So we recognize that inflammation can drive mortality independent of immunosuppression. Theoretically, we also know that azithromycin has additional benefit for prevention of MAC and also toxoplasmosis. However, the epidemiology in Africa is not well described, and no studies exist on the benefit of prevention of these infections in Africa. The reality in hasty antimicrobial prophylaxis was also seen to be cost effective. And reality could not distinguish between individual contributions of INH, fluconazole, azithromycin, and albendazole to the mortality and morbidity benefits from enhanced antimicrobial prophylaxis. Therefore, we should not take antimicrobial prophylaxis out of a package until we have more evidence on the potential effects or side effects like resistance development. So in conclusion, we are all actually at bay that cotrimoxazole preventive therapy and TB preventive therapy are the undisputed basis for antimicrobial prophylaxis for patients with acute HIV disease. However, additional to this, azithromycin and albendazole in this case, as given in the reality trial, should be given a chance to adults with acute HIV, advanced HIV disease when the CD4 is less than 100. Plus, we make sure that fluconazole preventive treatment based on positive crack screening and exclusion of cryptococcal meningitis is also considered. So we have the evidence from a very strong bundle intervention trial, and we should not have the habits to pick and choose only what pleases us in reality. I therefore urge you to clearly vote with both your hands and feet for prophylactic antibiotics for this very vulnerable patient population, where potential antibiotic resistance in the future needs to be blessed against, balanced in an imminent risk of early death today. So I'd like to thank actually the organizers for allowing me to come on this, but also I'll thank Professor Hugh Institute from Partners in Hope and Dr. Tom Heller from the Lighthouse, who actually worked with me to look at some of this data from different companies, and also the original trials which have been coded into this company. I thank you for listening, and greetings from Malawi. Thank you.
Thank you so much, Sam. And now we will hand over to Mark for the, after hearing that very strong case for, to hear now the case against. Mark, over to you. And please do type in your questions for the speakers.
Okay, so thank you very much indeed. A wonderful argument put forward by Sam, some of which I agree with and some I don't. And thank you very much indeed for the opportunity to put a counterpoint to this argument. So we are all currently living through a pandemic that has seen in 13 months 2.3 million deaths from COVID-19. And so we are all well aware what death rates look like in a major pandemic. We are also sitting in the middle of a major pandemic of antimicrobial resistance. And by the year 2050, 10 million deaths will occur each year from antimicrobial resistant infections. And the hammer blow will fall in big HIV prevalent areas such as Africa, Asia, and Latin America. Big numbers tend to leave people cold, dissociated, and distanced from the reality. So I thought I'd just bring you back to what the reality of resistance can mean. So this, in 1899, 40 years before the first use of penicillin, a man who was mowing the grass at a YMCA in the US cut his toe on a blade of grass. It became infected, and the only way to save his life was to amputate his foot above the ankle. 1 week ago in my hospital, a patient came in who had been given an antibiotic in the community and came in with an infected prosthetic knee joint with this pan-resistant Acinetobacter baumannii complex infection, which was resistant to everything, the tiger side breakpoint, and colistin was the patient to save her life underwent an above-knee amputation. Of modern medicine, as we know, increasing antibiotic prescribing needs to be looked at very carefully, and the pros and cons are made. So Sam did a beautiful introduction on the Mordor Trial, which was a trial looking at azithromycin to reduce childhood mortality in sub-Saharan Africa. And as he showed you, in Niger, there was a significant reduction in mortality when azithromycin was given on 4 occasions over a 6-month intervals over a 2-year period. However, in Malawi and Tanzania, there was no significant difference, but overall the composite mortality had reduced. Now, the WHO then convened a guideline group, of which I was a part, to try and understand whether we should or shouldn't roll out azithromycin to all children under 5, and the answer was no. Important other public health interventions should be strengthened, and mass drug administration with azithromycin should only be given to children under a year of age, where there was a very high under 5 mortality rate. And one of the reasons for this was relates to the potential harm, including resistance. Now, Sam also put pictures up of Mordor. Yeah, for those of you who know the Lord of the Rings, that will recognize Gollum, the creature who is transfixed by his precious, the ring, which he is here, unfortunately, destroying in the fires of Mordor. And what I'm putting to you is, with the use of widespread azithromycin, will we destroy our precious in the fires of Mordor? So if you look at the issue of antimicrobial resistance, antibiotic resistance to azithromycin in various bacteria, this is where I disagree with Sam, who my learned friend said that there was no evidence for resistance from azithromycin. This was pre-Mordor in First Nations Australian school children, single dose azithromycin, showing the proportion of carriage of azithromycin-resistant strains clearly increasing at 2 to 3 weeks and maintaining at 2 months. And then even at 6 months, still a higher rate than at pre-treatment. And also specifically, the azithromycin-resistant strains within those strep pneumonia were increased. Furthermore, in our own area in Africa, Ethiopian children who had been undergoing azithromycin quarterly treatment for mass treatment of trachoma at a longer time point, at 12 months, still had an increase in resistance to azithromycin in strep pneumonia. And then a systematic review showing that the median prevalence of genotypic resistance at baseline after mass administration of azithromycin for trachoma was 20% azithromycin resistance in strep pneumonia. Depending whether you gave an annual or biannual, it was thereafter either 40% or 60%. So there's clear impact on resistance in strep pneumonia. Now you may say, well, I don't need azithromycin in strep pneumonia, I can use penicillin or something else, but much of the world actually does rely on azithromycin, and particularly at times of international stockouts. The Mordor study itself, when they looked at a cluster randomized trial in Niger only, also showed that the groups that had received azithromycin, children had an increased rate of azithromycin resistance in strep pneumonia, and also their microbiome showed, in their gut, showed resistance to the macrolides greater than in the placebo group, which was statistically significant. Other bacteria, Chlamydia trachomatis, no effect, but Staph aureus in Gambian children, there was an adjusted odds ratio of increased azithromycin resistance. In E. coli, which isn't usually treated with macrolides, also showed adjusted odds ratios of increased resistance. In these studies, Campylobacter and Salmonella typhi wasn't assessed. So one of the questions to ask yourself is, how valuable is azithromycin to you? Well, I put it to you, if you've had Salmonella typhi infection, particularly in Pakistan, where this particular strain, which was XDR, and basically only oral drug available was azithromycin to treat it, I would say that you would think it was pretty important. And so anything that potentially caused resistance within Salmonella typhi could be pretty serious. Now, unfortunately, this seems to be spreading, and in this Ganges study, over 20% had azithromycin resistance. And actually 20 minutes before this this webinar started, this was posted on ProMed, showing that in Singapore, 2 out of 3 azithromycin-resistant Salmonella typhi had been found as local spread, and this is extremely concerning as the only oral treatment left. Is gonorrhea important to you? Well, it's certainly important in HIV programs, and this headline of a man who got the world's worst super gonorrhea probably wouldn't have got it if he or she had actually used the condom that they've got in their pockets. But gonorrhea is also extremely concerning, and we've seen over the last 60 years the progression of resistance, first to penicillins and then all the way through to XDR and basically last resort gonorrhea, which is, as you know, treated currently with drug regimen including azithromycin. And the percentage even in 2004 was concerning in some high HIV prevalent areas. And the more azithromycin you use for anything, the more you're going to drive, and particularly in adult populations and at the time of HIV, if they're not properly screened, you could engender azithromycin resistance within gonorrhea, and you are potentially looking at untreatable gonorrhea. And a variety of papers have shown how important it is in pharyngeal or oropharyngeal gonorrhea as well, which is particularly susceptible to resistance. Also in Africa, yaws is an important disease, and azithromycin is the basis of mass drug administration for yaws. And here again are countries which clearly, yaws being a non-venereal treponeme infection, there are clearly countries in red where there are high HIV prevalences, and the more azithromycin you put into a population, the more likely you're to engender resistance. And here is the first report of the emergence of azithromycin-resistant Treponema pallidum petuniae, the cause of yaws within a village. Lastly, I would say that in children, the antibiotics may not be the best thing for you. In early childhood, your microbiome and microbiota, in other words, your gut bacteria and the genes that are expressed in that, within the first years tend to move from a childhood type picture towards adulthood. And that's important in the production of our immune response, including systemic immunity. If you're given antibiotics in childhood, that progression can be interrupted, and you can lead to persistent microbial alterations or even transient microbial alterations, which have immunological effects and potentially clinical consequences. And you will be aware that there have been a number of associations now linked between antibiotic use in children and obesity, diabetes, inflammatory bowel disease, and even autism and spectrum disorder and neuropsychiatric illness. So antibiotics in early life may actually impact on diseases in the future. And obviously this is a question of future versus here and now, but you can't dismiss this. So in conclusion, mass drug administration of antibiotics drives resistance due to selection pressure because of those antibiotics. The anti-extended prophylaxis regimens you've heard about actually do raise important concerns and have potentially very significant effects on antimicrobial resistance in serious infections that kill and can cause massive issues, potentially with HIV transmission. If you start being unable to treat gonorrhea effectively and continue gonorrhea in patients, then the shedding with HIV and potential increase in transmission is something you actually need to stop and think about. And so prophylaxis and treatment of persons living with HIV with any antibiotic should be very carefully considered. And I would ask you to think again, look at the evidence and really ask yourself whether antimicrobial resistance is not an issue that you should be taking much more seriously, and be very concerned about increasing the amount of antibiotics that you give. Thanks very much.
Thank you very much, Mark. Another extremely strong argument, and you've encouraged us to look towards the past, but also look towards the future in terms of the potential burden of disease that antimicrobial resistance may pose. So please, if anyone, we do have a few minutes, so if anyone in the audience has some questions, please do raise them. In the meantime, I see Di Gibb from the panel has a quick question. Di, would you like to ask your question?
Yes, I was just to ask Mark, really. I mean, I totally agree with just about everything you've said. I think the issue about using prophylactic antibiotics, though, maybe does need to take account of risk benefit. And here you're talking about a population with a high risk of dying very soon after starting ART, where the diagnostic possibilities are very difficult, and where in those unknown deaths, where we really do think that bacterial infections probably play quite a high role, that you that is very different from giving it to populations of asymptomatic children. And so, and we do know that antibiotics are thrown around the place far too much, and surely regulation is the way to deal with that, rather than being too blanket about saying you shouldn't use azithromycin as prophylaxis. Sorry, just be devil.
So if I can respond, I totally understand, Di, and I agree. And if only it was as easy as saying that regulation could stop people prescribing antibiotics inappropriately, and we know that that's unfortunately not the case. I mean, I think what I've really heard today from a lot of the trials. I mean, fantastic trials, amazing work, and I spend most of my time treating HIV patients in Huddersfield who are in very advanced HIV. So I have great sympathy with this issue. But the reality is, what we actually need is better vaccine coverage and better diagnostics, and that's really critical. I haven't seen good studies showing whether or not adult vaccination can really reduce pre-ART vaccination by a few weeks, could potentially reduce deaths in the same manner as your bundle, for example. We know that there are a variety of vaccines that could be used and do impact on mortality in children and also in adults. And yes, the diagnostic, there's a real need for diagnostics. It'd be very interesting to see your azithromycin resistance rates in your study, and also the azithromycin resistance rates from the BREATHE study. But I appreciate it's not a blanket all or none, but I do think people, you really need to think very carefully. And the gonorrhea issue in Africa is potentially extremely serious, I would say.
Okay, thanks, Mark. We've got a couple more questions in the chat that I think are directed towards you, and then we also have a hand raised in the audience, so we'll try and let that person just ask a question directly. I think the questions in the chat are along similar lines. We have one question saying we're talking about HIV positive children at high risk of dying. Is the amount of children that we're going to be treating going to contribute significantly to resistance? So, I guess with the, azithromycin, one of the most widely used antibiotics in the world, many, many millions of doses prescribed every year, used in a semi-targeted way in people at very high risk of death. How could you sort of expand, maybe, and Sam as well, could you expand on how you see the risk benefit there? Is that something you could imagine with a certain evidence threshold being reached?
Perhaps Sam would like to start off.
Sam, would you like to just those questions about the risk benefit, and we may not be talking about huge numbers treated. How would you respond to that point?
So actually, I just responded to Anna, who actually wrote that. We are looking at a targeted group here of people with advanced HIV disease. So I'm also looking at, we're looking at what would be actually, we are balancing on talking about their risk of dying and also their risk in terms of being prevented from severe infections by using the antibiotic. And then to look at whether that will contribute significantly to the resistance that Mark is talking about. So in this case, I think comparing the mass treatment and in this case, the targeted group is a different actually thing altogether. So I am thinking that the contribution of this less targeted group would be less in the resistance compared to what can be used actually beyond that. That's what I would say for now. Thank you.
Okay, thanks, Sam. So that it might be a way of balancing the risk benefit. Mark, do you want to respond quickly to that?
No, I mean, I think the issue is that unfortunately, whether you use antibiotics in the correct way to actually treat a bacterial infection that's required or not, still will affect the microbiome, the microbiota, and colonization, not only in the gut, but also elsewhere. And, you know, that has significant impacts on future treatments of patients potentially. And within those first weeks and months, your patients may actually, these kids and adults may need to be treated for other infections. And if, you know, as I showed with that Acinetobacter case, unfortunately that patient had been given, you know, an antibiotic, coamoxiclav, which, you know, is rolled out all over the place, but it's selected out. So it's not, you know, this is not a small risk. This is a significant potential risk. And if, you know, you maybe need to also just separate whether you're talking about just children or adults. I mean, when you're talking about adults, you know, you are talking about a much larger number than I think you're suggesting, and that can impact. And unfortunately, yes, of course, there are lots of azithromycin being given, but that's not a reason to be very careful. Plus, you haven't yet proven that these people, these kids and these adults are actually, when the adults are dying of bacterial infection. I appreciate the caveats of problems with diagnosis, etc., but you haven't proven that yet. So, you know, there needs to be a balanced argument to this, and resistance, unfortunately, is a significant issue.
Thanks, Mark. Sam, I think a question directed more to you. Strengthening programmatic public health responses to get more people early onto antiretrovirals. The questioner says maybe a better mitigation strategy than prophylactic antibiotics and will reduce collateral damage. How would you respond to that argument? Sam, I think
Sure.
Yeah.
Yes. So I was trying to. So what we're trying to look at here, because most of the programs that we are managing are really a public health approach, and even what we're talking about here is talking about the public health approach. And in this case, yes, it's not actually, although it is not a one-size-fits-all, and also we're trying to balance here what we think, what the benefit is going to be in the end. So we will still ask people to come early to make sure that they're started on treatment early. But we've seen so far that even within the test and treat, where people are coming in, testing, not actually referred by a clinician, but they just came in for VCT. And we've seen so far that I remember we have some of them have a CD4 count of, let's say, below, in that case, actually below 100. In that case, it means that people could be walking around and think that they are well. But in this case, actually, they will still be moving into a category of advanced HIV disease. So what we're trying to do here is, much as we put the patient information or the public awareness, we still want to make sure that we target the people who have advanced HIV disease, because this will even happen even while they're on treatment. Let's make sure that we cover those in this case, and we're gonna have a good outcome within the National Public Health Program. That's what I would say.
Okay. No, thanks very much, Sam. I think we'll just run a couple of minutes over, if people could indulge us, just to let the speakers have a chance to wrap up. We did have a hand raised in the audience that we have allowed to speak. If that person still wants to speak, please do go ahead. If not, I think let's wrap up as we're at time. We said 2 minutes for your closing arguments, but perhaps Sam and Mark, if you could very succinctly perhaps try to wrap up in 30 seconds or so, and then we will have a final closing poll. Sam, would you like to go ahead?
So thank you, Akhil, for that. So I think the audience, you've heard the components where I brought up to say that we see some benefit in actually use of antibiotics, because we know that we've not ruled out for those who died at home. They could have died on actually conditions that actually would be covered by these. So we've heard actually Mark talking about more in his arguments about mass treatment. Now, well, he has gone into mass treatments components. What we are talking here is about a targeted group of advanced HIV disease patients. For example, in Malawi, at a Lighthouse and the Multiplex clinics, these are two busy clinics. They are big in Malawi, initiating between 800 and 2,000 patients per year on antiretroviral drugs. Approximately 25% have a low CD4 count in that case. And these amounts to about 700 patients per year that you would want to make sure that you start them on these antibiotics. So in that case, I am emphasizing that we can sleep quietly about the very small mass treatment what we are talking about, because it is targeted. Therefore, I actually enhance that we continue and we include additional antibiotics into the treatment of advanced HIV disease in order to reduce the mortality and morbidity. And I implore you to actually support that motion. Over. Thank you.
Thank you very much, Sam. And over to you, Mark.
Thanks very much. I don't sleep well at night, Sam, because 10 million deaths per year from antimicrobial resistant infections by 2050 is enough to keep me awake. My argument was actually just using the Mordor trial to exemplify, the use of azithromycin and the data that we have from there. But if you remember, I also presented data where a single dose of azithromycin was associated at 12 months with increased resistance in strep pneumonia. And we know that single dose of azithromycin in gonorrhea can be enough to cause resistance to azithromycin, and that's the only orally available drug and will play havoc with your HIV program. So I don't sleep easy. I don't think anybody else should sleep easy. And unfortunately, any antibiotic that is given at any time has to be justified. I would like to see proof that these people are actually dying of bacterial infection before I'm able to weigh up the evidence for and against for the harm or benefit from an antibiotic. Thanks.
Thanks very much, Mark. I think it's been really an excellent debate. There's a lot, I think, that will have given people to think about, to take back. We will just now ask you a couple of final polls. So if we could have the poll, this is the same question we asked you before the debate. We should routinely use additional prophylactic antibiotics in people with advanced HIV disease. Do you agree or disagree? You've got about 15 seconds to complete the poll. And I think we will, if we could just close the poll there and have the results. So the results are more even than they were at the beginning of the debate. We had 2/3 of people for the proposed motion and 1/3 against. Now we have 56% in favor and 44% against. So just to understand your thinking, we have a very quick final poll, which I think we can bring up now. I think who has, yeah, if you could just indicate how you have changed your mind, or in what way, having considered, really significant arguments and points in both directions that need to be weighed up in what is not at all an easy question. Okay, so I think we can stop the poll there. Most people did not change their mind and indeed remained in favor, but we do have 18% moving from agree to disagree, and a smaller number, 7%, moving from disagree to agree. So thanks really to all of our speakers for the incredibly good presentations. Those are going to be available. We will send everyone who's joined this session a link to all the presentations, to a recording of the session, along with any supporting materials that may be useful to send out. I think this debate has just designed to generate some discussion and thought and interest. Obviously, we all practice according to our local guidelines and practices, and we're not saying to adapt that. We're exploring here what is an interesting area, an important area for discussion. So thank you very much to our debaters, to our panelists, to all of you for joining, and we hope to see you at the next Advanced Disease webinar. Thank you.